Good evening, friends. Today we have two talks on lung cancer. The first talk is on awareness of lung cancer. It will be delivered by Dr. Bhuvan Chugh. As we know that lung cancer is very important because most of the cases are picked up as stage 4 disease. And in spite of NDCT and very serious programs to detect cancer at the early stage, and even those cancers which are operated, which are considered operable, and once they are operated, about 50% of them develop metastasis over a period of time. There was no hope. Patient survival was for 1 or 2 years, but now it has changed with the targeted therapy. I think we'll be hearing a lot about that. So it's very easy, very important to pick up the lung cancer at an early stage. I think change in the character of cough in a smoker, a subtle changes in the left hilum with both the diaphragms at the same level, meaning there is phrenic nerve palsy, or if there is a scanty hemoptysis in a smoker, you should never leave these patients without investigating with a CT scan and a bronchoscopy. If you just leave, okay, we'll see, it must be due to trauma somewhere, it doesn't work out like that. If you treat them at an early stage, the patients have still chances, and with the advent of these targeted therapies, by immunological treatment of these cases, I think the prognosis has improved and 5-year survival is possible. Dr. Bhuvan Chugh.
Hello, thank you Dr. Mangla, and to begin with I'd like to thank Physician Forum of India. This is my third CME with Physician Forum of India, and I think I can so understand why you all are such a strong knit family. It's been amazing seeing all of you come together every weekend. This is the third time I'm coming to see, and each time I've seen a similar attendance, and I think it's really heartwarming when you see that people who come together every Wednesday for a educational event, which is very difficult in a private practice otherwise. I'd also like to thank Pfizer, who's organized this meeting. The purpose of this meeting was to obviously make aware, educate you all about the lung cancer, and also at the recent advances in the lung cancer which have happened. So, I am Dr. Bhuvan. I'm a medical oncologist who looks after breast and thoracic cancer. The reason I say breast and thoracic cancer is because I don't think, as a medical oncologist, with the advancements which my field is undergoing at a pace of a new drug being added almost at a daily level, plus the new genes being added at the daily level, I don't think I have the luxury of doing everything. Will eventually have to restrict myself to possibly 1 area or at max 2 areas. I have chosen to restrict myself to breast and lung cancers because that's what interests me. I'm interested in genomics. I do a lot of precision medicine in terms of the gene-based. You understand the tumor at the genomic level and then you target the therapies. And the lung cancer has been the poster child for precision medicine, in which you understand lung cancer at a very molecular level, and that's where you treat it as. I don't think there's any lung cancer patient in advanced setting which doesn't undergo a genomic testing. It's been a routine, be it anywhere, be it in India, be it in Africa, be it anywhere in the Philippines. Even if there is a person sitting in tier 3 town of India, that will also probably undergo a genomic level, and that's the advancement which has happened there. So we understand that lung cancer essentially has a huge burden, not because the number of cases are high, because the lung cancer, once diagnosed, has the highest mortality rate. Among the cancers, if you look at it, the lung cancer is the one which has the highest mortality rate. Almost ballpark around 45 to 50% of lung cancers are picked up in advanced stage. So if you ask me, I'd be very candid to say that it's become more of a domain of a medical oncologist than of a surgical oncologist, because you rarely find a lung cancer which is early stage which is operable, and that's because it's a deep-seated tumor. By the time you have symptoms, most of the time the patient's tumor has generally spread out of the start from the primary side. So, to quote certain facts and figures, it's obviously a cancer which numbers are rising. It's patients are developing a lot of cancer these days. I more than me, I'm sure most of you, rather all of you I see here, are almost equal to me or senior than me, and you're seeing how the number of cancer patients have changed in the last 3 decades. The number of patients who had cancer has been growing rapidly, and it's I think a lot to do with our lifestyles. There's a certain risk factors which we attach to ourselves which have possibly led to this increased rise in cancer, other than obviously more detection is happening. In a female, lung cancer is the third most common cancer. We do agree it's far behind breast, but then breast, most of the cancers are early stage. Lung, most of the cancers are advanced stage, and that's the difference. In males, it is the most common cancer. It competes very tightly with prostate cancer, but it's still the most common cancer. But what is important is, among the two, it is placed at almost in the first 1 or 2 cancers, and it remains the most common cause of cancer deaths in both sexes, and that's where the importance of lung cancer lies, and detected at early lies. So the number, as we've told you, that it's obviously increasing. It's varied. The patients in North America, they have slightly higher. I think it's possibly because of the screening which we do. In Asia, they're obviously somewhere between Europe and Africa. That's where we are. In India specifically, there are almost 72,000 new lung cancer cases are diagnosed each year. And as I told you, the ballpark of most of them being diagnosed and having a metastatic stage, that is an advanced stage, is almost around 45 to 50%. Similar is the number in females. So what we need to understand is, there is lung cancer in female is a different biology altogether. It's not the same lung cancer as in males. There is a different way you treat a lung cancer in females. They behave differently. They are more driven by mutations, which is my domain. But essentially, it's not that it's uncommon in females. 25 to 26,000 all new lung cancer patients are diagnosed in females every year. It accounts for a ballpark of 6% of all cancers. It accounts for almost 8% of all cancer-related deaths. The smoker to non-smoker ratio is 20:1. It still is a disease of smokers. I would not say that it's not a disease of smokers. It's still a disease of smokers. And the demographic patterns are almost similar to what we see in the West. As I told you that tobacco consumption in a form of cigarette smoking or BD smoking remains to be the most common cause. There are obviously these the rising level of pollution, which I'm sure Dr. Nangia will obviously apprise you of what is the risk factor, but then yes, there's a definite risk factor with rising level of pollution in lung cancer, and it can't be debated anymore. It has been proven in studies. So coming to the etiology of cancer, it's the smoking, and there's a tobacco smoke, there's environmental exposure to certain carcinogens. These are the most common etiologies of lung cancer. Types of lung cancer, I think I'll probably skip to the part where we generally understand that lung cancer is either a small cell type or non-small cell type. The small cell type is a different set of lung cancer, which is more aggressive, it's more lethal. You rarely have a person surviving more than a year and a half with a small cell lung cancer. If you have a non-small cell lung cancer, it's again squamous and adeno, and the squamous is slightly more common than Adenocarcinoma is slightly more common than the squamous. It is also more mutationally driven. As I told you that adenocarcinoma is the most common type of cancer. It accounts for almost half of lung cancer cases. It is comparatively more frequently seen in non-smokers and in former smokers, and this is also the more common cancer in females. Patient with lung cancer, which are adenocarcinoma, they have more of a mutation-driven cancer. I don't know if it is of interest to you, but I think the moment you have an adenocarcinoma, the moment you have a lung cancer coming to you, and the moment we do a biopsy, what is of interest to me is what type of cancer it is. And I think what I will, the one message I want to give to you is, let me tell you the median survival for a lung cancer, which possibly will interest you, because so when I started my dissertation, India didn't have the molecular targeted therapies. It was that watershed moment in which the targeted therapies, that is the tablets, were coming in. The median survival of a lung cancer, not far, let's say to 2010, the median survival of a metastatic lung cancer in 2010 was somewhere around 12 to 14 months, and that's what our textbooks say. Now with that number in mind, the median survival of a lung cancer in metastatic lung cancer in today's is 5 years. So in the span of 14 years, we have increased the survival by 5 times. How has that happened is by doing and choosing the right molecules for the right patient. So essentially, when I had in 2010, when we started treating a lung cancer patient, there were generally 2 chemo drugs or 3 chemo drugs, and they used to be given one after the other, and the first chemo drug would give you a disease control of somewhere around 6 months. The second would give you somewhere around 4 months, and the third would give you somewhere around 2.5 months, and the patient would eventually die in 12 to 13 months. Now when I have a lung cancer patient, the way I treat it is, we spend time with them, we send it for genomic analysis, and there are obviously nuances of sending a genomic analysis which is not part of the discussion. If one of them have a mutation, which almost 40% of them have, if you take 100 cancer patients, 40% will have a driver mutation, and mind you, this number is increasing day by day. The number of mutations are increasing, the number of targeted therapies are increasing. They may have a certain cost attached to it, yes, but eventually the cost will come down. All of us have seen that in the last 5 years, the cost has come down substantially. So if I start a patient who has a driver mutation for which I have a tablet, for which I am saying there is a 40 to 45% will have those mutations, the single tablet, 1 pill a day, will give you a disease control of almost up to 3.5 to 4 years, 3.5 years. Now compare this to 6 months which you had via toxic chemotherapy in 2010 to 3.5 years with a simple tablet a day. Now understand the leap of science that has happened in the last 1 decade, that it has made lung cancer a disease which can be easily controlled. And once you fail that drug, that's not the end of line. Yes, and that's where my job as a thoracic medical oncologist comes in. So please understand, anybody sitting in a tier 2 city will be able to tell you that this is what you need to do in the first line. If somebody has a EGFR mutation, ALK mutation, blah blah, you give this drug, fair. But when you progress from there, how do you deal with that situation is where a thoracic oncologist expertise comes in. How do you check what to be done after that? What is to be given to them, these patients? And that's where a team-based approach, and that's where difficult biopsies are required. And that's where I require the expertise of Dr. Nangia when I said, this is a very difficult biopsy, but I need that tissue from there. Because it will tell me what I need to do more. And in case we are not able to get this tissue, all I need is a blood sample from a patient to identify what to be done later. Now this, I think it's very easy to say, and I'm jealous of Western countries because of the research which they're doing. And I think as an Indian oncologist, the thing which I'm missing in my practice is the original research, which empowers me to develop new drugs, which I'm not sure. I think in my lifetime as a professional, which I think I have 2 to 2.5 decades left at least, I sincerely wish and I sincerely know that I'll be able to be part of certain trials in which a new drug has been developed has been presented to one of the important forums and has changed life. That is what has happened in the last one and a half decade, and that's what we want to do also. So one of the drugs which we are talking about today is, there is, as I told you, there is this certain set of it. There is a lung cancer, non-small cell, small cell, and I think it's not important. It's something which is it's known to us. Now this is what the EGFR landscape is. This is, look at the FDA approvals. This is 2015. I don't think it's 2015. Let's call it as 2015 only. So this is 10 years worth of journey of EGFR. Before this, again, understand this 5-year journey, this 10-year journey is the one which has changed the median survival of a lung cancer from 12 to 14 months in a EGFR to now almost 36 to 38 months. Now all of these molecules are very well, they're less toxic, they're easy to take, and this is just one part of it. If they don't have it. The European conference this time has made another set of drugs which are used to be used in second line. So what I'm trying to say by all this is that essentially there is a lot which can be done. It's just that the disease has to be understood at a level where we pick the right drug for the right patient. Similarly, if you look at the ALK treatment. Now, I don't know if they have electives like yes, a lot of. So there's this lorlatinib is the drug, and it's rather a magical drug which Pfizer has it, and possibly for the right reason they are picking it up. Patient who had brain metastasis in lung, and they are 50% of lung cancer patients. So 50% of lung cancer patients will develop a brain met. Lung cancer is the most common solid organ cancer to cause brain metastasis. As a rule, whenever there is somebody who has a lung cancer beyond T2 stage, that is somebody who is more than 3 centimeter, 3.5 centimeter of lung mass, I'm supposed to do an MRI of the brain because there's a 50% chance they'll have a brain met somewhere in the line. Now, if somebody had a brain met to begin with, the median survival was 6 to 8 months. And if you look at the lorlatinib curves, the patient had progression-free survival. That is, the patient disease remained controlled without any radiation to the brain almost 36 to 38 months. Now understand that I am not talking about survival, I am talking about disease control. Patient who survived at 6 to 8 months now has disease control only for 36 to 38 months. And that is by 1 pill a day. And that's where the penetration of these drugs to brain comes in. That's where, now understand, whenever you give a radiation to somebody, there are obviously radiation associated side effects. Patients have a fatigue, there is certain degree of headaches which they end up having, there is certain degree of amnesia, there is some memory loss they tend to have. So all this has changed. All this has changed remarkably in the last year and a half, last half a decade. And that's where the real magic of medicine. So I don't think you should look at medical oncology as fascinating as from lung cancer, because lung cancer is super fascinating to a medical oncologist. It's something which is obviously the poster child. Well, but similar advancements happening in the other fields also. And this is where the guidelines come in. Alectinib, brigatinib, lorlatinib, they're all first-line drugs, all wonderful drugs. But I think what I'm trying to say is, my take-home to you as a mixed population of doctors would be, first, lung cancer in a metastatic setting is not a death sentence now. If when the patient comes to you and you see a lung mass, if you can just tell your patient to be a bit patient for us to help understand the disease better, we will be able to provide a solution. Second, a few tests are required before I'm able to make a judgment call as to start a medicine. So what we generally end up happening is, most of the patients when they have cancer, the first thing they want to do is to start treatment. I think what is rather important is, if I spend 3-4 days studying his disease, getting the answer, I'll be in a better position to give him a drug which is the most suitable. And if that calmness if you have that calmness which you can translate to your patients, and when they come to us and they believe that you have passed on that message right to them, that be calm, there is a solution, I think that will do the job for us. Thank you.
Very good.
The second talk is by Dr. Vivek Nangia. It is on the role of pulmonologist in lung cancer. We all know Dr. Vivek Nangia. He is the principal director of pulmonology, critical care and sleep medicine at Max Super Specialty Hospital. He is involved in the teaching of DNB students. Let's hear from Dr. Vivek Nangia what is the role of pulmonologist in lung cancer.
प्लांट को डाले फोटो में सामने आएंगे यार यही
Welcome, Dr. Nangia, yeah, guys.
Thank you. I guess I'm also a part of the family by now, having been here I guess 3-4 times in the past. It just feels like homecoming. I wish I could come more often and attend the other CMEs also, but unfortunately due to constraint of time and distance where I stay is what is a major limiting factor. But thank you all of you for coming here this evening. Thank you Dr. Chauhan for inviting us, and thank you Bhuvan for laying down the foundation for lung cancer. Lung cancer is really becoming very, very common these days. If you actually see, it's the second most common cancer globally now, with most common cancer in men in India and the second most common overall even in our country. We are seeing young ladies with no exposure to smoke. See, traditionally lung cancer was always considered to be a smoker's cancer, as Bhuvan also showed that you have smoking and there's a very strong correlation with lung cancer. But I guess no longer, with the kind of air pollution, the kind of diseases that we have, we've had young ladies coming to us, 28, 30 years old, with lung cancer. My own very close friend's sister was barely 40 years then. This is about 5-6 years back. She just developed a pain in the back which was ignored for a month. And then because she thought, she'd been pushing a lot of furniture, they just recently moved houses. So totally ignored for 1 month, and then when she went in for her scans, it was already a CA lung which had metastasized into the vertebral body, and within the next 2 weeks she developed a collapse of the vertebral body, C4 or C5 probably, and went into quadriparesis completely. And 2 weeks later she was no more. So that is the extent that lung cancer can just suddenly present. So you need to keep your eyes and ears open and never ignore any symptom is what I've learned now, especially after COVID, what we've seen. I think every single symptom needs to be taken very, very seriously. So what is our role as a pulmonologist? Bhuvan has very well explained to you that how the management of lung cancer has evolved and really transformed the management of all these patients now. So our role is, I wouldn't say from the beginning till the end. There's a huge major part that Bhuvan and his team play in our patients. Our job is for screening, diagnosis, staging, handing over the patient to them, and then when it comes to end stage, for palliative care. This is what we do. So why I've listed all the symptoms here is to tell you that any of these symptoms can come to you. Any patient can come to you with any of these symptoms, which could be confused with tuberculosis, with an interstitial lung disease, even with asthma for that matter. Ultimately, it's a proper workup that these patients require right from day one, and which can save a life. There could be patches on the X-ray like this, which could appear to be tuberculosis. People are being started on antitubercular medication, without any further diagnostic workup being done, just based on X-ray. I think we've moved a long way from that. That is something that we should not be doing anymore, that any patient with a patch in the lung, even if the patient has a classical history of low-grade fever, weight loss, night sweats, cough, hemoptysis plus minus, a patch on the X-ray, MON2 positive, quantiferon gold positive, no, this could still not be tuberculosis. It could still be so many other diseases, including autoimmune, including fungal, including cancer. So they still need a proper diagnostic workup. Even if it is tuberculosis, you should treat the patient only once it's sputum positive, gene expert positive. You've seen the sensitivity pattern. If it is rifampicin sensitive, still you must get an XTR gene expert done or a Haynes line probe assay done to see whether the patient is also sensitive to INH or not, and then continue with the routine 4 drugs. But looking at the gene expert is very, very essential these days. Without a culture positive or without an AFB positive, it's not right to be starting somebody on treatment like that. There could be various types of presentations for cancer also. There could just be nodules, masses, opacities. Even on the CT scan it becomes difficult to differentiate sometimes. This is a case report that we published some times back, where this patient was being treated as tuberculosis just because it was a cavitating mass in the lung. And we all know, even in cancer, especially squamous cell cancer, it can present with cavitating masses. So you need to have a biopsy, you need to have a confirmed diagnosis before starting the patient on any treatment these days. So for diagnosis, apart from the sputum examination, we rely a lot on bronchoscopy. Why? Because bronchoscopy gives us a dual advantage of diagnosis as well as sometimes it could be therapeutic. In fact, there are times when you just do a bronchoscopy. What is bronchoscopy? It's the endoscopy of the lungs. So what do? The moment you put the scope in, sometimes you get a picture like this and you know what it is. This is classical carcinoid, nothing else. And all you need to do is just snare it out. So just a visualization can also give you a diagnosis sometimes. But of course, when it comes to proper endobronchial growth that you see, it is important to take some FNACs, biopsies. So we usually start from there. The first, the brushings, just to be safe that the patient is not bleeding. Then inserting a needle into that tumorous growth, so that again to ensure that the patient does not bleed. Otherwise these tumors can sometimes bleed so profusely that do what you may, it will not come under your control. And then, so FNAC, then you can do endobronchial biopsies and confirm what it is. This is a biopsy being done in a patient with endobronchial growth, and this is probably a cryobiopsy. So we've moved on from conventional biopsies to now cryobiopsies. Cryobiopsy has the advantage of giving you a larger tissue, a more confirmed diagnosis, a better tissue material which can be used for NGS, which I guess is very, very essential for Dr. Bhuvan and his team to get the new gene sequencing done to be able to give the appropriate therapy. So none of these procedures can be underestimated at any cost or bypassed. These are all the various ways of getting a biopsy done so that you can get to a definite diagnosis. Sometimes people say that the cost of bronchoscopy has gone up so much. Believe me, the cost of the bronchoscopy procedure is not much. It's the allied processes, the registration charges, the admission charges, and then the diagnostic workup. There's so much of diagnostic material that you need to be sent that the labs want for biopsies, for microbiologies, from PCRs. So collectively, the costs go up significantly. But again, it's basically, if you break up the cost and see, it's the investigations that are the major bulk. So if the total cost is say about 80,000 rupees, 45,000 or 50,000 of that would be only for the diagnostic work. Because then when we take out the tissue, we also send it for microbiological examinations, we also send it for histopathology, TB cultures, AB cultures, so on and so forth. So as I said, we moved on to cryobiopsies now. Cryobiopsy is a procedure that we do under general anesthesia with the patient completely under control. Patient is put on an endotracheal tube with a blocker inside, and then we take biopsies from the lung the size of the biopsy is equivalent to what you get on a VATS biopsy. So that is the kind of yield that you get. So as a result, for any disease, whether it's a diffuse parenchymal lung disease, interstitial lung disease, tumor, infection, anything, for anything that you need a biopsy, we've moved on to cryobiopsy now and not just a simple biopsy. As you can see here, look at the size of the tissue that you're getting. It's almost like taking a wedge biopsy from the lung or a VATS biopsy from the lung. There are also these novel visualization techniques which include the autofluorescence bronchoscopy, which have a yield of sensitivity about 80% and specificity about 83%. They basically guide you if there's any precancerous lesion or any mucosal lesion inside the lungs from where you may need to biopsy. So they basically help you guide towards an unhealthy mucosa. There's also narrowband imaging, which is designed to detect angiogenesis and neovascular lesions. Then when it comes to central airway tumors could be causing an intrinsic compression. These are the ones which are most easy to diagnose, where you just need to puncture and take the material from this. Extrinsic stenosis is the one which is tricky because you really can't see anything. And then mixed stenosis also is not so difficult because there is an endobronchial growth. So what do? So you then move on to what is called a therapeutic bronchoscopy, where you need to now open up the channels. You have an airway where there is a tumor infiltrating, the patient is finding it difficult to breathe. So what would you do? You will have to cauterize it, open it, burn the tissue inside. I remember way back in 2005, 2006, there was a very elderly gentleman who just came to us with sudden onset breathlessness. No other symptom prior to that. I was at Patra Hospital then. So this elderly gentleman came to us with sudden onset breathlessness, type 2 respiratory failure, lined up on the ventilator. When we put the patient on the ventilator, there was not so much of wheezing, yet the peak airway pressures were very high. So we did a diagnostic bronchoscopy and there was a growth that was obstructing the endotracheal tube. So endotracheal tube was actually sitting over that growth. Temporarily we could save him, but we didn't know what to do now. There was, at that time, radiation was not an option, chemo would have taken us time, patient is on an endotracheal tube. We did not have any kind of electrocautery machine with us at that time. So there was this ENT specialist in Daryaganj. So we borrowed his machine from there, and the guy would come in an auto, his technician, and would charge us 5,000 rupees for that one day that he would send the machine. So we cauterized that lesion, and it was so fruitful that the patient could be taken off the ventilator the next day itself. So that was my first experience. After that we've done several such patients, and I'll just show you. Now there are several equipments that you can use, from laser, APCs, electrocautery, cryosprays, mechanical debulking with a rigid bronchoscope. We've gone beyond that now. These are all the various modalities that can be used, the various advantages and disadvantages of these modalities. This is brachytherapy. Brachytherapy is basically a localized kind of radiation. This also we've done for our patients. You just introduce a catheter and then connect it to the radiation machine, and the catheter is left inside for a few days, and it goes on burning the tissue from inside only. So there's no external beam radiation that is being given to that. So once you've actually opened up the stenosis with the help of cauterization, I'll just show you here. This was the patient where we've done an electrocautery to open up this web stenosis inside and then introduce a stent into this patient. If you see the stent, it's again a very simple procedure which could be done just with the usual conventional flexible bronchoscope or a video bronchoscope, where you introduce the bronchoscope, look at the extent of the lesion, put in a guide wire, pull out the bronchoscope, then thread the stent over the guide wire, release the applicator there. The stent just opens up. There is a self-expanding metallic stent which just opens up and takes the position there while you're guiding it with the bronchoscope parallelly. And after this, when you do the bronchoscopy again, instant relief. There's an instant relief to the patient because all that stenosis, the narrowing of the airways has gone completely. So then we have another modality which is called EBUS. EBUS is the endobronchial ultrasound. Endobronchial ultrasound basically helps in the accessing the mediastinal lymph nodes. Mediastinal lymph nodes could be malignant, non-malignant, could be tubercular, there could be, so you need it for staging as well as for diagnostic purposes. So what basically is endobronchial ultrasound? This is a conventional bronchoscopy TBNA that we used to do at one point in time. Probably video is not working. But from this, we moved on to what is called EBUS. This is basically a bronchoscope which has an ultrasound at its tip. So when we introduce a bronchoscope with the ultrasound at its tip, we are able to identify where the lymph node is and then use a needle to puncture and take the material from inside. We also do what is called ROSE, that is rapid on-site evaluation. So while we are doing the procedure, we keep sending our slides to the cytopathologist who's right next door, and the cytopathologist helps us report that what are they finding. So basically the advantage is that you're able to get a diagnosis there and then. It's like a frozen section that you do. And here the advantage also is that if the first sample is negative, you can pick up the second sample, second is negative, third, so you don't stop till you get an answer. Something wrong with this. Apart from that, you can also use the endobronchial ultrasound to access masses which are paratracheally, which otherwise could not have been reached. This is not something amenable to a CT guided biopsy which would have gone transcutaneous, so you needed something from within. So EBUS is used to take a biopsy from here easily. So this is an FNAC, and again, as I said, it's an era of inventions. The amount of invention that I have seen during my career, it's like amazing. When I started my career way back in the late 90s, the bronchoscope was also a rare commodity, and now from bronchoscope to FNACs to EBUS to now biopsies. So now what we've started doing is a new thing which is called transbronchial mediastinal cryobiopsy. So now when you have a lymph node in the mediastinum, the FNAC is not sufficient. Again, Bhuvan would ask us for larger tissue because they have to do NGS. So what do we do here? We take cryobiopsies from inside the lymph node. So you have the airways, outside the airways are the lymph nodes. So we do the EBUS, identify the site, put in the needle first, widen the hole there. Through the hole we introduce a 1.8 mm catheter which can be used for picking up the tissue from inside. That's a cryo probe that you're introducing and pulling it out. What is cryo probe? Cryo probe is nothing but it has a kind of a freezer at its tip. So the moment you apply cryo probe, you freeze the tissue. When it freezes, you're able to take a chunk of the tissue and pull it out. It's a very simple procedure, but the only risk is bleeding, so you need to be careful about that. And the patient needs to be under GA and fully under control. So this is where a cryobiopsy is being done. And this is now a routine feature for us, doing a cryobiopsy from here, cryobiopsy from the mediastinal lymph nodes, cryobiopsy from the lungs, and also a cryobiopsy from the pleural tissue is the next thing that we've started doing now. So these are the various tumors that can be accessed, and with hardly any complication rate really. When you have a mass inside the lungs, then we use what is called a radial EBUS. Radial EBUS, basically this is to identify the growth in the parenchyma, because again it is a blind procedure for us when you're doing a bronchoscopy and there's an alveolar mass around the airways. If it is not endobronchial, then it is in the parenchyma. So how do you know where it is? One of course is to see the under fluoroscopy, but fluoroscopy is also not 3D. This is what is 3D. So when we introduce this catheter inside, again it's like an endobronchial ultrasound. It is able to identify where the tumor is, and then you can take precise biopsies. So it's an era of precision, it's an era of innovations that we're going through these days. And of course, future is with intratumoral chemotherapies, and with the transbronchial needle, chemotherapy is being introduced into the tumors successfully. You can also think of radio frequency ablation, which I think is just about to come in this country also. And then again, when you have patients with massive pleural effusion, again, the same thing that I would want to repeat. Any patient with a massive pleural effusion, especially elderly or those with a history of smoking or exposure to biomass fuel, pleural effusion, you do a pleural aspirate, you get an exudative effusion, lymphocytic predominant, ADA borderline, please do not start this patient on antitubercular medication. Get a pleural biopsy done. For these patients, we do what is called a medical thoracoscopy along with a cryobiopsy. Medical thoracoscopy gives you double advantage. One, that you're able to drain out the entire fluid, whatever amount it may be, 1 liter, 1.5 liters, in the same sitting you're able to drain it out and gives patient immediate relief from the compressive symptoms of breathlessness, cough and all of that. And also it gives you a window to take a biopsy from inside, which again would have a yield of touching 90 to 95%. Even if it turns out to be tubercular, it gives you tissue to put it up for AIB staining, gene expert, gene XDR expert, the line probe assays and all of that. So you can get a definite diagnosis, tubercular as well as microbiological diagnosis, to be able to start the appropriate therapy. So this is a medical thoracoscopy happening with a patient who had typically a lymphocytic exudative effusion with low ADA, had been started on antitubercular treatment outside somewhere. We did the biopsy. These are the nodular opacities inside the pleural cavity. You pick up biopsies from there, send them, and this is what turns out to be malignancy. So this was a mesothelioma that the patient actually had. This also gives you, thoracoscopy also gives you the advantage to understand how the lung is going to behave after removal of fluid. If the patient's lung is expanding and you have seen that this is 100% malignancy just by visualization, then you can even instill TAG inside there and then to cause pleurodescence, to help in pleurodescence instantly. Why? Because these are the patients who are going to refill the fluid very soon. In no time, you drain the fluid out and they'll come back to you with effusion. By the time we get the biopsy report, we hand over the patient to Dr. Chugh, they start the chemotherapy, the results would take some time, the effect of the medicine will take some time. By then, we do the pleurodescence for these patients so that our job is done and there's no recurrent filling of pleural effusion there. If the lung does not expand, endoscopically you're seeing and you're seeing that the lung is not expanding, it's remaining collapsed, then you know this patient is not going to improve with this. So you just put in an indwelling catheter and leave it there for times to come, till the chemotherapy becomes effective. Then one other common symptom that patients of endobronchial malignancy can come to us is with hemoptysis, which can be sometimes massive, uncontrollable, not coming in control with Trenexa, with your ethamsolates and those codeine linked syrups. So what do you do in these situations? You can do an endobronchial blocking, you can put in endobronchial blockers. So we've had a good success using the common Merocil that Dr. Parashar would be using to stop epistaxis. We have used it now for closing bronchopleural fistulas in patients with pneumothorax, not improving otherwise, not unfit for surgeries, in controlling the hemoptysis, because all you need to do is just go into the desired segment from where the patient is bleeding and just put a blocker there till the bleeding stops. We recently had a patient with MDR COX positive with a large cavity in the right upper lobe and bilateral disease. But the large cavity from the right side was bleeding continuously. He'd been treated with ATT for a month with no response whatsoever, was unfit for a general surgery. So we did his bronchial artery embolization first as a first step, but he continued to bleed. So then we went in with an endobronchial blocker, blocked his the upper lobe bronchus with just Merocil. We cut the Merocil is a large piece that you get. We cut it into smaller pieces, smaller chunks, just put it inside. With the Merocil, it just expands on its own and blocks the bronchus completely. Of course, we had to put in 3 or 4 of those pieces, but then the patient recovered fully, and just 2 days back, he called me up to say there's been no bleeding for the last 2 months, and the repeat X-ray is showing much improvement on in the cavitatory lesion as well. So with those words, I'll finish my scientific presentation and invite you to my new clinic that I've recently opened. This is in J5 Green Park Extension. This is a state-of-the-art clinic where we have a complete lounge with a huge reception with a lot of aesthetics that have gone into developing this clinic. We have an eye center. We have my own chamber and a pulmonary rehab center with complete respiratory labs, sleep lab, Dr. Dang's collection center with us. and this is my office set, and it will be a pleasure to have you all over. We have a couple of chambers which are lying vacant during the day, so in case any one of you is interested, or any one of you know who might be interested, are most welcome to contact me, and we could work out the modalities. We also have a conference room there to adjust about 20 people. So sometimes if you have a smaller group and you want to hold a meeting there, you're more than welcome to be there. Thank you so much for a patient hearing and inviting me.
Dr. Nangia sir, please come here. So you can. I think we had two wonderful sessions. I give it to Dr. P K Mangla sir to take it forward from here.
Thank you, Dr. Nangia, for extensively covering diagnostics and palliative care in lung cancer. I want to just highlight one point, that if you get a patient who complains of chest pain, and if he gives you the history that he takes a tablet, the pain disappears, and again after 6 to 8 hours the pain comes again, it is certainly malignancy. You must investigate this patient. It is 100% malignancy. So never ignore the symptom of pain chest in a patient, which is so typical. It is open for discussion. I think we start with Dr. Bhuvan Chugh, and then we'll come to Dr. Vivek Nangia.
With your permission, sir, Dr. Bhuvan, wonderful presentation. And you beautifully pointed out, sir, a few years ago when we told the patient that you have mass in the lung, it was like a death sentence. Sir, what has changed the landscape of prognosis in lung malignancies? Is it immunotherapy or it is something else? Is it we have certain very credible drugs now which actually control the disease process? Your comment on that, sir?
So I think there's this book called as The Emperor of Maladies.
Sir, can you be a bit louder for that?
So there's a book called as Emperor of Maladies, in which there is this chapter on Nixon's war on cancer. So I think the way we understood cancer and the way the National Cancer Institute in US tried to make changes into the understanding of cancer is what has changed quite a lot. So obviously the modalities have increased in terms of diagnosis, in terms of staging. But what has also changed is the way we used to understand cancer as one group of disease, as one disease. Now each disease is being understood at a very, very molecular level, and that's where the advancements are supposed to happen. So if you look at the clinical trials which were available to us possibly 10 years before to what the clinical trials are available to us now, they are no more. So you will not find a clinical trial for lung cancer anymore. You will find a clinical trial for lung cancer, non-small cell, EGFR mutated, post-osimertinib exposure with this mutation. So what I'm trying to say is my understanding of cancer has changed drastically in last 10 years and 10 to 15 years, and that's where the advancement in disease has come in, advancement of life has come in, and most of the drugs which are also being made now are also specific to a particular type of cancer, and that's what has rather brought about a significant change in the survival of the advanced cancers. When you say immunotherapy, most of the early stage cancers, again, we have understood the biology better. We have understood that for a cancer to happen, something has to go wrong in your body to allow it to happen, for which the immunotherapy comes in. So basically, yes, in early stage also there are these drugs which have come in which have allowed us to, like for example, you must have read through that NEJM paper in which rectal cancer patients who didn't require surgery and they could just be given certain drugs and didn't require surgery at all after that. That was because they were able to identify a subgroup of patients who had that cancer which is of a particular type, which just requires some setting of drugs and no more surgery. So understand, a rectum cancer patient who probably would have lost his continence, who probably would have had to carry a stoma for the rest of the life, now has the option of doing an organ preservation. So that can only be available once you understand the disease better. That's
Sir, we know that we have wonderful treatments now available even for advanced stage cancers, but prevention is better than cure. I would like to invite your comment on any wide-scale screening tools that are available, and is there any government-sponsored program for screening lung cancers in India?
I think the prevention will definitely start from not smoking, and prevention from exposure to even a second hand or a third hand smoke. That's something which is very, very vital. When it comes to government-sponsored programs, I personally am not aware of any government-sponsored programs which I think...
Anything available, sir? Anything being sponsored by Government of India?
Mass TV program.
So basically, I don't think lung cancer is still a focus for the government as yet. They're focusing right now on tuberculosis only, as far as lung diseases is concerned, not even COPD or asthma or any other disease. So their focus primarily is to eradicate tuberculosis. So all the funds, all the attention is diverted there only, but nothing on lung cancer.
Sir, any message for our specialist GP friends to pick up lung cancers, especially in high-risk groups like smokers?
Absolutely. I think the biggest message that I want to give everybody, and that I've repeated on the dais also, on the podium also repeatedly, is that please do not consider anybody with a shadow in the lungs to be tuberculosis only. We need to think beyond that. Even if it says repeatedly that yes, it's TB, even if the radiologist says it's consistent with TB, but unless the patient is microbiological, so those are things that I think are easily avoidable. TB I know is rampant in our country, yet I say repeatedly that microbiological diagnosis is very, very essential.
Sir, coming to Dr. Bhuvan, sir, broadly, the advances that are taking place in the prognosis are with the known small cell carcinomas. What is happening in the arena of small cell carcinomas? Any good news?
So, small cell carcinoma is called as a recalcitrant disease. It's like a disease which possibly it's very difficult to make advancement with. However, what has come out in small cell malignancies is we're able to figure out what drives small cell lung cancer. It's primarily the AKT inhibitors, AKT as a mutation, and then there are standard RB1 and P53s, TP53 mutations. So in the last 3 years, we've had 2 new immune checkpoint inhibitors which have come into small cell, which have increased the survival from the previous 6 months to almost 14-15 months now. So that's been a year increase in the survival of the small cell lung cancer. That's one. Another is this new set of drugs calling as AKT inhibitors, which gonna be new advancements as a part of second line in small cell lung cancer. And third is, once we are obviously waiting for the newer generation of molecules which are coming in beyond the AKT inhibitors, which are also still in the clinical trial phase. We still not have has an exposure to them. They're still not approved, but I think that will be the third line which will possibly be included in the armamentarium of small cell lung cancer.
Sir, coming to the specific of today's talks and the molecule being marketed by Pfizer, sir, what is the cost of this therapy? Any idea for our friends?
I think it's somewhere around 1.5 lakh rupees a month, 1,30,000 if I'm not wrong.
And how much is the total duration of treatment?
See, most of these drugs, they have their patient assistance programs, and if the patient, I'm not aware of the patient assistance program. Is there a patient assistance program? What is it?
It is 1+1.
Take it.
So it is 1+1 for first year, 1+2 for second and third year, and for fourth year it is 1+3. Then in fifth year 1, and the entire year 3. So it is like that, and cost to the patient will come down to around 1.25 per month, including assistance for first year, because it is 1+1. The actual cost is 2 for the month is 2.50. So if you include 1+1, then it will come down to 1.2.
I was just wondering, has there been a head-to-head trial with immunotherapy with this drug?
So, I think we're talking about two separate set of diseases.
Yes, sir. Yes, sir.
Non-small cell lung cancer, which is driven by so let's divide non-small cell lung cancer into oncogene addicted and oncogene non-addicted. So these drugs are part of the oncogene addicted part of non-small cell lung cancer. It is widely known now that oncogene addicted non-small cell lung cancers do not respond to immunotherapy.
Okay.
So even if they may have a high immunogenic score, they generally are very poor responders to immunotherapies. They rather are good responders to the targeted therapies. So there is never going to be a head-on trial in that case.
Sir, do you have a personal experience of using this drug?
Yes, definitely. So again, as I told you, the real mark of this drug has been in the field of somebody who has a brain metastasis or leptomeningeal metastasis. So now understand, in a leptomeningeal metastasis, if a lung cancer patient has a leptomeningeal metastasis, it's a death sentence. You are looking at a median survival of 2.5 to 3 months. And out of those 2.5 to 3 months, the patient is going to be bed-bound for most of the time. Now with this drug, you are looking at a disease control rate of somewhere around 18 to 24 months with just the drug. And somebody who has a brain metastasis, it is also giving you a disease control in the brain. Let's say somebody who had a lung cancer to begin with, but did not have brain metastasis. At the end of 5 years of this drug being given, rather 3 years, I think they came out with the 5-year data, only 1% of the patient develop brain metastasis. And I'm talking about the other figure is 50% will develop a brain metastasis. So essentially, a very huge role of this drug is in the somebody who has brain metastasis, and which you definitely want to prevent brain metastasis. That's why the subset it's hugely beneficial.
Great, sir. Dr. Nangia, sir, my very relevant question, which I think appeals to me. There has been seminal work done by Mount Sinai researchers on low-dose CT scanning to pick up and for the screening programs. I was wondering, in our kind of a setup, does chest X-ray pick up malignancies, sir? Your honest comment on that.
Right. So chest X-ray, one is chest X-ray can only give you an indication towards a possible malignancy, but not really pick up a malignancy. Yes, their yield will be very, very poor. So that is why internationally they recommend the low-dose CT scan to be done in all the high-risk group patients. So at least for us, for patients who can afford, you should get a CT scan done every year after the age of 50 for somebody who has more than 30 years of smoking back here history. So it will be worth it really.
Sir, what are the red flag signs in a chronic smoker when we should suspect malignancy? Is it the change in the character of cough?
Change in the character of cough, any blood, loss of weight, loss of appetite, fever now coming in, breathlessness, chest pain. There would all be things that you need to watch out for. Otherwise, they keep attributing it to smoker's cough, smoker's cough, smoker's cough. And the worst is that the patient themselves come and influence you by saying that this is just a smoker's cough. So many times you have to tell them, bhai, tum isko chodo, symptom batao. Kis wajah se hua hai, wo chodo. Leave that to me to decide what is happening. Even just recently I had this father and son duo, both smokers. And the son had come in with a nodule of 8 mm in size in the lungs. And now panicking, but again attributing the cough to the smoker's cough only. Every time, so they try and brainwash you. They try and influence your decision making, that this is all smoker's cough, so ignore it. But you have to delete what they're talking and only focus on the symptom that they're presenting.
Dr. Parashar.
Thank you, sir, for taking my name from the podium. Thank you. What about the Marosil use? You put in the Marosil there, then you have to repeat a biopsy, take it out, or you put a thread and you can pull it out?
So as of till now, we've done it about 3 or 4 patients. So about 10-12 patients of bronchopleural fistula that we've done it in. We've not had to remove it. In 3 or 4 patients of hemoptysis we used it in. we haven't had to remove it yet. They usually cough it out themselves or just let it be there till.
What about the atelectasis at all?
No atelectasis because these were all diseased portion of the lung anyway, so there was no ventilation happening there at all.
Any role of rigid bronchoscopy now?
Rigid bronchoscopy, you know, there are people who are for rigid bronchoscopy, there are people who are again, not against, but somebody like me who has done every possible procedure with a flexible bronchoscope. Whether it is fiber optic, whether it's foreign body removal or insertion of a merocell or doing a stenting. So except in my indication, the only indication is to put it, if you are putting in a silicone stent, that you need a rigid bronchoscope. Otherwise, in 25-30 years of my career, I haven't used rigid bronchoscope ever. Only with flexible bronchoscope, I have never felt any limitation and done practically all procedures that are written in the book.
So my first question is in relation to Dr. Mangla, chairperson's comment, that all the chest pain cases where pain recurs after 6 to 8 hours taking a maybe considered malignancy. What about musculoskeletal pain? Because that will recur after 6 to 8 hours for few days.
These pains are different. You know, it is the tumor has got the nerve. It's a very severe pain. Musculoskeletal pains are different. You know, it is a localized pain at the site, and if he gives you the history, I have had 2-3 patients, and both turned out to be malignant. Even if it didn't appear on the chest X-ray, there is anything. So you should be very, very serious about this part.
So this type of pain will not be localized. What you are talking about, malignancy, pain or malignancy?
It will be localized. It will be localized because it is at the site where the tumor has picked up, caught up the nerve.
Okay. So, Dr. Nangia, what about, we always blame smoking and cause of malignancy. What about Delhi pollution and how much it contribute to in relation to smoking in causing lung malignancy?
Yeah, very good question, I think. So as I said in my talk also, that smoking of course was lung cancer was always considered to be a smoker's cancer. But I don't think it's any longer. Of course the incidence amongst the smokers continues to be very high, but there's a significant number of people who are developing adenocarcinoma, which is non-smokers' lung cancer. Squamous cell carcinoma is more with smokers. Adenocarcinoma is more in non-smokers. Young ladies, non-smokers, developing cancer. Cause, it's anybody's guess. Of course, air pollution would be a major reason. 25 micrograms of air pollution, AQI of 25 mcg, PM 2.5 particle of 25 microgram per meter square is considered to be equivalent to 1 cigarette smoking.
What about passive smoking?
So that means if it is 100, that means 4 cigarettes smoking. If it is 400, that means 16 cigarettes smoking.
What about passive?
Passive, very good. So again a very good question. Passive smoking. So what happens basically is that passive smoke also contains the same amount of toxins and carcinogens, which is almost to the tune of 4,000 chemicals, more than 50 identified carcinogens in the cigarette smoke, which could be causing lung cancer. Out of which, so when a patient himself is smoking, when an individual is smoking, he's only inhaling 1/3 of the smoke and 2/3 is coming into the environment around him. So passive smoking is even more harmful than smoking himself.
Patients are more vulnerable than the hazards of the occupation. That's what
over to Dr. Tulsi and Dr. Evan Kalrastan.
Thank you, Dr. John. So those are some excellent talks by Dr. Nangia and Dr. Chugh as well. So Dr. Nangia, so cancer statistics in India from National Cancer Registry program said 1 in 68 people, males would develop lung cancer. That comes to about 6.9%, and 1 in 29 females breast carcinoma. 1 in 9 Indians, all of us, would probably develop cancer in one of our lifetime. So that's horrendous. So talking about lung cancer, Dr. Nangia, 44 to 47% of the people would be diagnosed after metastasis have occurred, and 80% will report in advanced stages of stage 4 cancers. So how can we reduce this? You said probably X-ray test with artificial intelligence would play some amount of role, but low CT scan, low dose CT scan, probably the standard of care here now. And when would you recommend this? Do you recommend it for moderate to severe cases, or when? Is there a pack smoke?
30 years.
30 years?
30 years, pack years.
Yeah.
And anybody more than 50 years in age should undergo an LDCT every year.
So as we know, if we can detect, see with CT scan, the mortality of lung cancer will reduce by 20%. That's huge. So my next question would be, Dr. Chugh and Dr. Podaverizi, they talked about, causes of lung cancer. So smoking is foremost, pollution also they talked about. What about non-malignant conditions, you see, like COPD and interstitial lung fibrosis and tuberculosis? Do they, impart some amount of increased lung cancers here?
So there is something called scar carcinoma also.
Yeah.
Which happens in people who have long-term scars lying inside their lungs. So like post-tubercular lung scars, they could convert into cancer. ILD patients could convert into cancer. But again, the most tricky part in these patients is that the diagnosis becomes even more challenging for two reasons. One, that their symptoms are usually attributable. If somebody has an ILD, already has breathlessness. So even when there's a slightly increase, the physician would consider it to be an increase in the ILD only and start, upping the dose of the steroids and the antifibrotics, not wanting to investigate any further. So again, you have to have a very high index of suspicion with patients who already have a pulmonary morbidity to detect cancer early in these patients.
So do they contribute to increased incidence of lung cancer? The non-malignant conditions like COPD?
Absolutely. Why I am saying that is because as it is, they are also a result of some cigarette smoke, some air pollution. So obviously the factors are common. Whether it's development of COPD or development of lung cancer, the factors remain common. Even ILD smokers are known to have a greater incidence of ILD in them, IPF in them. So also for other conditions.
Right. So to Dr. Chugh, the poll is coming in between you and me. I'll shuffle it up. Okay. So stage 4 cancers. See, we have a new classification now, stage 4A and stage 4B. So targeted therapy or immunotherapy have advanced so much that it's really so interesting. The lung cancer patients are surviving, beyond maybe 3 years now with targeted therapy and immunotherapy. So what would you contribute this to? Because of the recent advances in targeted therapy, we have a number of molecules today in targeted therapy as well as in immunotherapy. Talk us through the latest targeted therapy and immunotherapy. Of course, also the biomarkers.
So that will be a conference in itself.
That would be a conference in itself. Where is Dr. Chugh?
Next conference.
Next conference, Dr. Padar says, we'll fix for that. The biomarkers. Go ahead, sir.
Give it in a gist.
Yeah.
See, I think what we need to understand is that how we used to proceed. So whenever you have these new generation of drugs coming in, you have a first line and then you have a second line and then you have a third line. So whenever there's a new drug entry into a particular disease subset, it comes as a third line or a fourth line. Because you probably would put your patient on a new drug till the time you know it's going to be better than what you already have. And then it starts climbing its way from third line to second line to front line. So I think it's safe to say in a concise manner that the number of drugs have increased. The way we choose these drugs, the technology has increased. And the way we used to manage the toxicities of these drugs, the experience has increased. So I think that's where the entire game has changed. the NGS itself has, the next generation sequencing has brought in a lot. If I can understand the genes by a draw of blood of 5 ml and gives me the entire information about the disease, obviously I'm more inclined to repeat it multiple times, so I get to know the disease better. So basically it has been advanced at multiple stages.
So the KRAS gene was non-druggable. Today it's druggable. So, see, and tomorrow's treatment is here at our footsteps today. So a lot of advances today in lung cancer treatment, sir.
You're absolutely right.
Thank you, sir.
Very nice talk, sir, both of you. Only 3 questions and 2 comments. Comments first. First comment is about X-ray, role of X-ray in diagnosing cancer and others of the lungs. It is as important or as useful as ECG for a heart problem. So it misses most of the problems.
No, I think I'll just have a comment here. There's a AI based Cure AI. There's a company called as Cure AI who's doing a very good work in terms of applying AI over the chest X's in which they're able to figure out. So I'm not saying that the data has reached a point where you and me can apply it in our clinic, but I think that AI based software is good to pick up pre-malignant conditions.
Maybe AI also enhances ECG later. So, passive smoking, I think 85% is the damage done compared to the smoker. Because smoker is smoking actively, inhaling the whole gush of it, maybe 1/3. The 2/3 is then dissipated. Person is not very close.
Active and passive smoking.
Yeah, passive smoking I think is 85% damage compared to the active smoking. I heard somewhere, I read somewhere, and I agree to that. So cryobiopsy, we were very fascinating, very new thing. Does it have any change on the morphology of the specimen which we have taken?
So on the contrary, the studies that have been conducted between a conventional transbronchial biopsy and a cryobiopsy, the yield, the structure, the tissue is much better in a cryobiopsy, not just the size but also the quality of the tissue that we send.
So it's rather preserves.
Better preserves.
Better.
So has there been any post-COVID surge in the cancers? Because cancer post-COVID, there was a lot of immunity issues, so many things. Has it made an injury to the lung during that COVID? Any data?
Yeah, your interview to the Indian Express just a day back talked about pollution and probably post-COVID also situations which probably enhance lung cancers.
Sir, our friend Dr. Nalin Nag died due to cancer. So I just wonder, is something new developed after his death?
And he was a non-smoker.
Yeah, I know. He was again a Moderator from my school only and a good friend.
All these therapies, we are seeing the slides were for quite some time. So was he not available to?
Another friend, Dr. Kaur, consultant physician cardiologist at Woolton Hospital, also died, but he was a smoker.
I have one small question. Wonderful talk, Dr. Nangia. How much is the role of radon gas in lung cancer? In the US, in some places, you have to take a certificate from the government before you can sell a house about the radon levels in the basement of the house. Is it?
So I honestly don't have experience with that particular carcinogen, I think.
But it's mentioned, there's always a passing reference to radon whenever, even in your slides it was there.
I possibly don't have experience.
Thank you.
Any other questions? Ankul, you have a question? Good, very good. Dr. Mangla's son, blossomed pulmonologist, not blooming but blossomed pulmonologist.
For the introduction. My one question to Bhuvan sir is, so what about the resistance of EGFR, ALK drugs, and also for the patients who have lung cancer with brain medicine, which you give osimertinib. In case the patients who progress on these drugs, then what about the other second generation drugs?
So I think it's a great question, and it's rather my area of research also. So I'll tell you why it's a great question, because and once a patient progresses on osimertinib, that's where my role as a thoracic oncologist comes in. The usual way the treatment of a post-osimertinib has changed is there is something called as Mariposa 2 trial, in which they use this drug called as amivantamab with lazertinib as one combination. Another combination is amivantamab plus chemotherapy. So what I am trying to get to is, it's important to understand why has the patient progressed after osimertinib. Osimertinib itself is a newer generation TKI. The way it attaches to the EGFR molecule, what has caused the resistance is where the entire molecular thing comes in. I had a patient with osimertinib who developed a C797S, which is one of the resistance mechanism, and I simply shifted the patient to the first generation TKI of gefitinib. The patient again got 8 months out of it. So why it interests me is because it takes me to a very deep level of molecular understanding, which is what excites me into this entire space. So each patient who has progressed after osimertinib, you need to understand why it has progressed and what can be done to overcome that resistance. So no one patient will have same answer. It will be different reason for different patient, and that's where the deep understanding has to come in.
And what about the resistance pattern of EGFR ALK receptors?
So again, for a osimertinib, EGFR is the star drug there. The most common resistance mechanism is C797S. There is a MET exon mutation. There is I've had a patient who had a EGFR, developed a RET, then developed an ALK, then developed a So again, what I'm trying to come to is, there are a number of resistance mechanisms for EGFR. We need to figure out which one it is. For ALK, I think they're more or so well defined. One of the journal, there is a new ALK mutation which tends to happen with the older generation of ALK inhibitors, which leads to their resistance. And if you are able to overcome that newer mutation in ALK, you'll be able to overcome the resistance. So if you had a crizotinib, you gave crizotinib, and now you're giving alectinib or lorlatinib, you'll be able to overcome the resistance which was there for the first generation of ALK inhibitors.
So one last question, sir. Many patients who are on immunotherapy, they developed immunotherapy-induced lung damage. So in that case, they have to be, after ruling out all the lung infections, and we are sure that it's due to immunotherapy, all the lung-related changes and clinical issues are worsening, dyspnea, cough. Then they are started on steroids. Then immunotherapy has to be discontinued forever. Then what for such patients in the future? Like immunotherapy is definitely contraindicated. Then what else to be given in such patients?
So there are two things which you said in that statement. First, we need to identify what is the grade of the toxicity. If somebody has a grade 1 or a grade 2 toxicity, a reintroduction is possible. Somebody who had a grade 4 toxicity, reintroduction is not possible. Grade 3, it can be a very individual decision. Generally, what is seen is that patients who have a toxicity have had a good response to the treatment also. So you may not need to treat them right there. Plus, once you've had a complete response or a partial response, the risk of reintroducing a mean checkpoint far outweigh the benefit there. But yes, once the patient is progressing, you'll have to figure out a non-immunotherapy treatment, in which obviously there are newer drugs which are there. You are able to use them.
Thank you.
Dr. Mangla sir, you need to summarize this wonderful CME both by Dr. Bhuvan Chugh and Dr. Vivek.
So Dr. Bhuvan Chugh, actually what are you sending? You are sending EGFR, ROS and ALK.
Yes,
TTF1?
I'm sending everything. I do a comprehensive genomic analysis. I think I've had n number of discussions among myself as in what should I be sending. I've had a patient, and I should not be saying it out because I'm a max person, but I've had a patient for which whom I sent a hotspot panel in my hospital, who young, so standard Asian female, non-smoker, sent a hotspot panel of limited genes. They missed the EGFR. I was not convinced that how can she not have an EGFR. I sent a comprehensive genomic panel. She came out to be EGFR. I've had a similar patient in the past, whom, again, a young male, non-smoker, 43-year-old, had lung cancer, sent a limited panel to SRL, didn't pick it up. The patient was not responding to treatment. We sent a foundation, came out to EGFR. So I've learned it enough in a hard way that you have to send a CGP, you can't do it upon spot. You'll miss out. If you're missing out 1 in 50 also, that one life is gone. For what? The test is going to be costing what? 30,000 rupees, 40,000 rupees extra for what you're doing. So send a CGP. Don't debate it, send a CGP.
Okay, wonderful lecture. I think pulmonologist role and medical oncologist role is amazing in managing lung cancer. And lung cancer diagnosis, meant a certain death sentence, and I think the life they spent was in hospitals and spending money. One of my patients which I had sent when I was in Sake City, this patient was very cooperative. He said, no, I want to get my father treated by the best doctor. And he came back after a year, 7-8 months. And he came out that I regret why I got my father treated. That can be the agony of chemotherapy, earlier chemotherapy I am talking about. One should be sensitive to the symptoms of patient, and as already mentioned, just don't be in a hurry to start ATT. ATT treatment delayed by a week or 2 weeks is not going to make a difference. If patient is not too toxic, not running fever, and has a suspicious opacity, I did a bronchoscopy and there was a right main bronchus mass. I took a biopsy and next day the diagnosis was there. This guy was a Jat guy. He carried on 30-40 people to the referral doctor's clinic. कि डॉक्टर साहब मुझे ये समझा दो कि उस अस्पताल में जाके डॉक्टर पी के मंगला ने ऐसा क्या देखा कि 24 घंटे में कैंसर बता दिया और टीबी नहीं बताया. Physician called me. I said you should have at least seen that the whole of lung is gone and there is a lot of iota of disease on the contralateral lung. That does not happen with TB. So things can be that nasty. You should be sensitive to the symptoms of patient. Investigate to the head. Don't think that if I miss, I miss. You cannot miss. Once your paper is gone, you are equally responsible for missing a diagnosis. Thank you.
Friends, we had a wonderful